Able to hear me? We hear you beautifully, Greg.
In fact,
Great. Well, it's great to be here. It's only about 14,000 miles away. And I was just watching Antonio's case and seeing Antonio, talking to Sushil in the background. Now I'm already hearing your voice. I feel like there's a great connection between New York and India. So I'm going to spend about 20 minutes talking about current and future drug-eluting stents. And this will be a whirlwind presentation of 20 years of technology. If you go to the next slide, when we talk about first-generation drug-eluting stents, we're talking really about the Cypher and the Taxus stents. And of course, we always describe these as three-component devices with the metallic backbone, in this case stainless steel for each, with the polymer which controls the drug elution and its dosing, in this case durable polymers, first-generation polymers which had some hypersensitivity and pro-inflammatory effects, and then the drugs, of course, paclitaxel on Taxus and sirolimus for Cypher. Next slide, please. There was no doubt that these drug-eluting stents were remarkable. And if you look at this slide, which has now actually been extended out to 10 years, drug-eluting stents allow us the capability of freezing the initial scaffolding effect of a bare metal stent, but through its anti-proliferative properties, being able to achieve sustained long-term patency in most patients. Next slide. But of course, there were downsides of all stent technology and of drug-eluting stents. We learned that drug-eluting stents were sometimes too potent. And this should be the next slide, showing the good, the bad, and the ugly. Sometimes the slides were too potent. And you could see that you could have lack of endothelialization, where you would only cover approximately 40% or so of the stent surface, out to around 3 to 6 months and beyond. And this is work from Renu Vermani and others. And this is probably the #1 cause of late stent thrombosis. By angioscopy, we could see this lack of endothelialization and at times persistent thrombus formation. We could see hypersensitivity and inflammatory reactions with eosinophilic infiltrates or giant cells from the different polymers. And you could get vascular and toxic reactions from these stents, which would lead to late positive remodeling and incomplete revascularization. Abnormal vasomotion, of course at the stent site, but also distal to the stent, was an issue, especially with the Cypher stent. And as a result, both Cypher and Taxus are prone to late stent thrombosis. Next slide, please. So we were very open and honest when we looked at the long-term outcomes of the Taxus program. This is the Taxus slow-release stent, Taxus 1, Taxus 2 SR, Taxus 4, and Taxus 5. And the first thing you see here is the undoubted benefit of drug-eluting stent technology. These are relatively simple or only moderately complex lesions. And you can see target lesion revascularization is markedly reduced by almost 50% within the first year. And then those benefits are sustained over time. And you can see no late catch-up, at least of the clinical effect, with follow-up of 5 years of these nearly 2,800 randomized patients. Next slide. However, we did describe an increase in very late stent thrombosis, that is beyond 1 year. And thus, if you look at the rate of myocardial infarction in this landmark analysis, you could see that up to 1 year, there was no difference in stent thrombosis between Taxus and bare metal stents. But between 1 and 5 years, the rate of stent thrombosis and therefore the rate of myocardial infarction increased. And statistically so there was about a 50% increase in myocardial infarction. Next slide, please. Now, when you would take this from simple to moderately complex lesions and extend the results of first-generation drug-eluting stent technology to more complex lesions, then we really saw the limitations of first-generation DES technology. So, of course, perhaps the most complex randomized trial ever done was the Syntax trial of patients with left main and triple vessel disease randomized to Taxus versus bypass surgery. And if you looked at the low Syntax score patients, Syntax score of 0 to 22, here Taxus does pretty well compared to bypass surgery, even with left main and triple vessel disease. with similar rates of death, myocardial infarction, and reductions in actual stroke. Only a slight increased rate of repeat revascularization. Next slide, please. But when you start looking at intermediate syntax score complexity, and then when you go to the next slide, when you look at high syntax score complexity, now you really start seeing the curves diverging. And you can see substantially higher rates of MACE with Taxus stents compared to bypass surgery. And what's particularly concerning is that you also see higher rates of cardiac mortality, all-cause death, and myocardial infarction. Next slide, please. One of the major reasons for this is because of stent thrombosis. So I'm letting you catch up to the next slide. And you can see here that at 4 years, stent thrombosis rates were actually almost 9% with the Taxus stent. About 1 in 11 patients having a stent thrombosis. And you can see it's very high within the first year, about 4.5% stent thrombosis within year 1, and then 1.3% per year between years 2 and 4. So there's no doubt that stent thrombosis contributes to this adverse rate of death and myocardial infarction. Next slide, please. Now, if we go to the second generation drug-eluting stents, first we have a class that's typified by Xience V and Promus Element that have, first of all, improved stent technology. They are now very thin strut cobalt chromium stents, much more flexible, much more malleable, much more deliverable, and the thinner struts allow faster reendothelialization. The polymer is now a combination fluorinated copolymer, and fluorinated polymers are known to be very thromboresistant and platelet resistant. And the drug is everolimus, which of course is similar to sirolimus in its potency and lipophilicity. So this is one class of drugs, Xience V and Promus Element. The Vision stent is cobalt chromium. The Element stent is platinum chromium. Next slide, please. Another second generation stent class is either Biomatrix and Resolute. And the Resolute stent is also, again, letting you catch up. The Resolute stent consists of a very thin strut cobalt chromium stent with a complex hydrophilic hydrophobic BioLinks polymer which controls the elution of zodorolimus. And I've skipped the Endeavour stent, which was somewhere between the first and second generation here. Endeavour was a similar type of stent, but used a different polymer, phosphorylcholine, which led to fast release of zodorolimus. And it was actually in many ways somewhat in between DES and bare metal stents in terms of its potency. But the Resolute stent is truly a potent stent because the zodorolimus elution is prolonged by the BioLinks polymer. And then we have the Biomatrix stent, which is a little bit older in terms of its, hold on one sec, a little bit older in terms of its stent technology with the stainless steel S-stent, but it is unique in that it has a bioabsorbable polymer on the abluminal surface. And this is really the first foray into bioabsorbable polymer technology, which I'm going to talk more about. And this is, of course, PLLA, which elutes biolimus A9, very similar to zodorolimus, sirolimus, and everolimus. Next slide, please. So if we look to see the advantages of second-generation stent technology, this has probably been most in-depth explored in the SPIRIT and COMPARE trials, looking at the Taxus stent compared to the Xience V/Promus stent. And SPIRIT 2, 3, and 4 and COMPARE have been pooled for a patient-level meta-analysis, and you can see 6,800 randomized patients. And the first thing you see is greater efficacy. So you see approximately a 36% reduction in ischemic target lesion revascularization with Xience V compared to Taxus. Next slide. And next slide again. Not only was it more efficacious in terms of efficacy, but it was also safer. And this is perhaps the most profound difference, that when you look at stent thrombosis, you see approximately a 70% reduction in stent thrombosis. 2.3% versus 0.7%. Next slide. The differences here extend to high-risk patients, and one of the highest risk patients that we've seen for stent thrombosis is actually patients with acute coronary syndromes. And if you look at the left on patients with stable angina, and then at the right in patients with unstable angina or acute coronary syndromes, we know that stable angina is much lower risk than ACS. And you can see ACS patients with the Taxus stent in orange have approximately a 50% increased rate of stent thrombosis. On the other hand, this is really eliminated when you go to the Zions V stent. Low rates of stent thrombosis, both in stable angina and in acute coronary syndromes. Now, overtly thrombotic lesions and ST segment elevation MI were excluded from all these studies, so the outcomes may not be quite that good in those high-risk patients, but you can see major strides have been accomplished here. Next slide, please. Now, if we look at Promus Element, the purpose of Promus Element was to be able to take the Promus or Zions V technology, which is a fluorinated polymer releasing everolimus from a cobalt chromium stent, that is the Promus or Zions V stent, and to transfer it to a more radio-opaque and stronger Promus Element stent. And the Promus Element stent offers trade-offs in terms of its deliverability, scaffolding, again, radio opacity and radio strength, but with less longitudinal or axial strength, making it somewhat more prone to longitudinal stent deformation. But nonetheless, when you look at the Platinum trial, which was a 1,530 patient randomized trial of the Promus stent versus the Promus Element stent, you see very similar rates of target lesion failure between these two devices out to 2 years, and very low rates of stent thrombosis out to 2 years, 0.6% with both stents. Next slide. Then finally, if we come to the Resolute stent, you can see Resolute also shows very similar outcomes in terms of target lesion failure to the everolimus-eluting stent platform. So if you look at the Resolute all-comers trial, again, this is about 2,500 patients randomized, all patients here randomized to Zions V versus Resolute, almost identical rates of target lesion failure to 2-year follow-up. Next slide. Now, one of the differences which has differentiated the everolimus-eluting stent platform has been the low rate of stent thrombosis. And this platform has been somewhat unique. Even though the others may match it for target lesion failure, there's now a wealth of data to suggest that stent thrombosis rates are not only lower with the Zions V everolimus, but also even compared to other drug-eluting stents and compared to even bare metal stents. So this was a trial called the Examination Study, which was 1,500 patients with STEMI undergoing PCI within 48 hours, so very high risk for stent thrombosis. Randomized to Zions V versus the otherwise equivalent Vision bare metal stent. And you can see that within 1 year, the rates of definite or probable stent thrombosis were 2.6% with bare metal versus 0.9%. I'm sorry, 2.6% with bare metal versus 0.9% with the drug-eluting stent. And definite stent thrombosis was also reduced by about 70%, from 1.9% to 0.5%. So this has been fairly surprising to a lot of people. Now you have to be a little careful, because 1,500 patients is not really powered to show a reduction in stent thrombosis. 70% is an overly optimistic true treatment effect. And so you have to ask yourself, are these data real? Next slide. So to address this question, Tullio Palmarini and his colleagues performed what is called an evidence-based network meta-analysis, looking at every trial that's compared all the major bare metal stents and drug-eluting stents to either each other, again, or to bare metal. And this was altogether 49 randomized trials, almost 51,000 patients. And here you can see the evidence network. So what a network meta-analysis does is it looks at direct evidence, that is a direct study B, pooling them, and then performing a meta-analysis. But it also looks at indirect comparisons. So for example, you can see that from bare metal stents, there were 9 studies that were comparing those two. From paclitaxel-eluting stents, to sirolimus-eluting stents, there were 8 direct studies that compared those two. And if you look at bare metal stents to, in the lower right-hand corner, platinum chromium everolimus-eluting stents, there were no studies that compared those to each other. But they're linked by studies that compared bare metal stents to cobalt chromium EES, and then cobalt chromium EES to platinum chromium EES. And so you can make indirect inferences of the relative safety and efficacy between stents that have not yet been directly compared. And this is a well-known, long-term accepted statistical technique. To me, it's obviously raises some questions compared to direct studies. So you have to take this again with some grain of salt. It's all hypothesis-generating data. But nonetheless, let's look at what the data shows. If you go to the next slide, when you look here at the 2-year rates of definite stent thrombosis with comparing every single stent to every single stent, there's only 2 differences that stand out. And that is that the Xience V cobalt chromium everolimus-eluting stents compared to both Taxus paclitaxel-eluting stents and bare metal stents have a significant reduction in definite stent thrombosis, about a 65% reduction in stent thrombosis. Again, and the fact that it's reduced compared to Taxus is perhaps not that surprising, but the fact that stent thrombosis may be reduced compared to bare metal stent is quite surprising. Next slide. So you then look at both the direct level of evidence and the indirect level of evidence. And as you can see, looking at both definite stent thrombosis and or probable stent thrombosis, the indirect level of evidence added to this meta-analysis is almost identical in magnitude to the direct level of evidence. And this really suggests that this is accurate data. So in other words, it suggests that the indirect level of evidence just added a magnifier effect to the direct studies that have been performed. Nonetheless, we would love to have a true 6,000, 10,000 patient randomized trial comparing bare metal stents to the everolimus-eluting stent to truly see if DES has now gone further than bare metal stent technology in reducing stent thrombosis, with the hypothesis being that it was because of the polymer being so thromboresistant and platelet-resistant. Next slide. So now what we're doing is to see if we can take this to more complex lesions and improve outcomes once again. So we've gone back to patients now with unprotected left main disease, but this time with the lower and intermediate risk scores, according to the syntax score. And this is the Excel trial. And this is a 3,600 patient trial with unprotected left main, syntax score up to 32, with 2,600 patients randomized to either the Xience or Xience Prime stent versus coronary artery bypass graft surgery. And so hopefully we will be able to show that we will now be able to do significantly better than was seen in the syntax trial in this group, be at least non-inferior for the important endpoints of death, myocardial infarction, and stroke, and perhaps even superior. And this trial is underrolling with approaching now 700 randomized patients. Next slide, please. So what problems remain to be overcome? Well, we're doing much better with current generation DES within the first year, but after year 1, even the best drug-eluting stents still have issues. So this is the 5-year follow-up from the SPIRIT 3 trial. Again, 1,000 randomized patients of Xience V versus Taxus. And if you look at just Xience V in blue, you can see from after year 1, there's about a 1.8% rate of target lesion failure per year. 1.8%. A little bit higher in Taxus, 2.5%, but still, it's not like you get to the 1-year period with Xience V and then this curve is flat. And every study has shown this. Next slide. So if you go to the real world, for example, and look at more than 12,000 patients from the Bern-Rotterdam experience looking at ARC definite or probable stent thrombosis at 4 years, you can see that yes, Xience V has reduced stent thrombosis compared to Cypher or Taxus in the real world over 4 years. Next slide. But if you go to this landmark analysis, you can see that yes, the differences are particularly pronounced in both the first year period and then from year 1 to year 4. But you can also note that even after year 1 through year 4, that there are still late events that are occurring even with Xience V and with Promus. So this is definite stent thrombosis, and as good as it's gotten, we can still do better. Next slide. So what is the pathophysiology of late adverse outcomes, and particularly very late stent thrombosis, that is after 1 year? Well, there may be multiple different pathophysiologies. First of all, there are still sometimes late polymer reactions that can occur. For example, with eosinophilic infiltration and late positive remodeling. You can still have delayed healing, and it may just be that drug-eluting stents, as potent as they are always going to cause delayed and absent healing, and may always be somewhat prone to very late stent thrombosis. But the new etiology, which has captured everybody's attention, which may become increasingly recognized as the common pathway of late drug-eluting stent failure for either stent thrombosis or restenosis, is that of neoatherosclerosis. And that is the chain of the typical restenosis phenotype from smooth muscle cell proliferation and extracellular matrix to now one that appears more to be atherosclerotic in nature, with actually necrotic core formation and cholesterol cleft and inflammatory cell activity. Next slide. So this shows some examples of mixed cases of bare metal stents and drug-eluting stents using radiofrequency IVUS or virtual histology to understand the nature of the underlying in-stent restenotic tissue. And here you can see that early on after stents, you will normally see mostly either dark green or light green. That is fibrous or fibrofatty tissue. And that's the VH signature for typical smooth muscle cell proliferation and extracellular matrix. But as you go out to a year to 2 years with drug-eluting stents, and then 4 to 5 years with drug-eluting stents and bare metal stents, this phenomenon occurs faster with DES and VMS. Now you start to see a lot of necrotic core appearing, and that's the red. And again, this is cholesterol, cholesterol esters, dead necrotic cells, macrophages, and lymphocytes with inflammatory activity. Next slide. Renu Vermani's lab is finding an increasing incidence of rupture of these types of plaques inside previously implanted bare metal and drug-eluting stents as a cause of stent thrombosis. And here you can see with a cipher at 23 months, a rupture of, you can see all the cholesterol clefts very easily with thrombus formation. And here you can see within bare metal stents at 96 months, the same sort of phenomenon. So this is increasingly recognized. You can see this with OCT as well, very, very easily, and you can see it with near-infrared spectroscopy, looking at the lipid core signature. And so we would like to come up with stents that either avoid or mitigate this phenomenon. Next slide. So there are 3 approaches to improve late drug-eluting stent outcomes. Either metallic drug-eluting stents with bioresorbable polymers, metallic drug-eluting stents polymer-free, and then fully bioresorbable vascular scaffolds, or BVS. Next slide. And I'm just going to give you some quick examples of these technologies because there's literally more than 50 altogether when you sum them up of technology being worked on. So first, I already described to you the Biomatrix Biolimus A9 eluting stent that uses PLA on its abluminal surface, that is the surface that's exposed to the vessel wall, to elute Biolimus A9, a sirolimus-like analog. And over a 6 to 9 month period, the PLA dissolves and is converted into CO2 and H2O, leaving behind a bare metal stent. Next slide. The LEADERS trial was an all-type study that randomized about 1,700 patients to the Cypher sirolimus-eluting stent compared to the Biomatrix Biolimus A9 eluting stent. And you can see here that when you look at overall definite stent thrombosis out to 4 years, there's no significant differences between the 2 stents. But you can clearly see after 1 year, there are increasing number of events with Cypher, but very few events with Biomatrix. Next slide. Such that if you perform a landmark analysis between 1 year and 4 years, you can see an 80% reduction in very late stent thrombosis, presumably by getting rid of the polymer itself and the propensity towards late polymer reactions. And again, this is very, very intriguing and very promising. Next slide. The Boston Scientific Synergy stent, which is now under investigation, is really taking this to the next level. PLGA polymer, in this case, not just PLLA, but PLGA, applied to the abluminal surface, but an extremely small amount of polymer, eluting the everolimus. And so far, the preliminary data look very, very promising for this stent from a 400-patient randomized trial, and this is now entering pivotal trials as well. Another technology is to use totally polymer-free surfaces, and that is by either micro-sketching or modifying the surface of a metallic stent so the surface will actually be able to bond and hold enough of the drug and elute it in a reasonably controlled fashion to be effective. So, for example, the Biosensor's BioFreedom stent, you can see this micro-structured surface without a polymer that holds Biolimus A9. And again, small early pilot studies are quite favorable. It's not so easy to make these devices, though. A whole different concept, which is undergoing development right now, is to use a drug-filled stent, which is a hollow cord-out stent from Medtronic, where the drug is actually in the center of the stent, in the center of this hollow tube. And based on the diameter and the spacing of the holes, you can very accurately control the elution of this sotorolimus. And this drug has not yet undergone first in man, but is certainly a novel approach to a polymer-free system. Next slide. And then finally, we have the fully bioresorbable vascular scaffolds, only a few of which are shown here. The first being Agaki Tamai, which was now placed in patients for more than 10 years without a drug, as a proof of principle that in the patients in whom it works, you could restore the native pristine architecture of the vessel without any late and long-term effects. The stent that so far clearly has the most experience is the BVS from Abbott Vascular, using an underlying poly-lactide stent with a PLDA coat which elutes everolimus. Next slide. This has been studied in now more than 600 patients, including the absorbed BVS cohort A and B studies and now the Extend study. And you can see when you look at this by OCT that post-stenting you get this typical corrugated appearance. At 6 months, you can see the tissue starts filling in, and the bioabsorption process is well underway. But you can see some pretty unnerving pictures, such as these tissue bridges that are being formed. But then by 24 months, you have almost complete absorption of the BVS, and you can see only small remnants of where the stent was, which is filled in with proteoglycan material. Next slide. One of the unique aspects of this stent is that it restores vasoreactivity, not only distal to the stent, but actually at the stent site. And of course, the ability of the endothelium to be able to react to pressure changes during systole and diastole, to have cyclic variation in tone, releases eNOS, that is nitric oxide, which promotes vascular health and vasodilatation. All of this, of course, is theoretical, and we will have to see if the stent resolving will lead to further improvements in long-term outcomes. Next slide. So with this in mind, there's a very ambitious ultimate pivotal clinical trial program which has been planned and will be starting within a few months, which is called the Absorb 3+4 trials. And this is going to be a total of 5,250 patients with 5,000 randomized. The first 2,000 randomized to Absorb versus Xience Prime with a non-inferiority hypothesis within 1 year. That is, we are hoping that Absorb is as good as Xience Prime within 1 year. But thereafter, we will have 5,000 patients to look at the outcomes from 1 to 5 years, with this trial being powered to show improvements in overall target lesion failure between 1 and 5 years for the BVS scaffold compared to the Xience Prime stent. So hopefully we'll be able to flatten out that curve that I had showed you in the Spirit 3 slide. Next slide. So Marty, in summary, these are the current and future directions in stenting. Current drug-eluting stents have appreciably improved both the safety and efficacy profiles for outcomes for our patients in both acute coronary syndromes and stable CAD compared to the first-generation devices. And outcomes can be further improved by ischemia-guided PCI. That's really another lecture. By utilizing small amounts of a bioabsorbable polymer, polymer-free systems, or fully bioabsorbable stents, future generation drug-eluting stents will likely further reduce stent thrombosis and improve late outcomes. Thanks very much for allowing me to give you this talk, and hopefully next year I'll be able to actually join you in India. Bye.
Thank you very much, Greg, for an excellent talk on the various aspects of drug-eluting stent.